Can we have Dr. Shrinivas?
Yeah.
Because just management of clinical management of endophthalmitis may not be enough, and then you may need a lawyer to help you out.
Thank you. Thank you so much. Very good morning, everyone. Thank you, Dr. Aditya Kelkar, for successfully conducting courses year on year and having a good audience and a very useful instruction courses. I'd like to thank the AIOS Scientific Committee for giving us this opportunity. So Dr. Aditya Kelkar has given me a very interesting topic, that is the medico-legal aspects in endophthalmitis. After Dr. Maiti spoke about endophthalmitis, how to handle it. So we know that intraocular infections has always brought disrepute to the ophthalmologist, and it can occur in the best of the hands, and only surgeons who do not encounter endophthalmitis in their practice are those probably who do not operate. So what's the million-dollar question? If you have a misfortune of infection, then how to save yourself in the court of law? Maintenance of the proper records, both ocular examination pre and post-surgery complications, recording of the minute details of medical treatments, X-rays, ultrasound pictures, ECG records, reports of irrefutable proof of any proper diagnosis and treatment, hence are extremely important. Now I have mixed up with the Supreme Court judgments also along with these things. The hospital and the doctor were guilty of deficiency in the service as case records were not produced before the court to refute the allegation of a lack of standard of care. So important here is, please maintain proper records. Consent forms, express consent either given in writing or expressed in words. Such consent always protects the doctor. So nature of the condition he is suffering from, the options of the treatment which are available, the advantages and the disadvantages of the surgery, the associated complications, material risks associated with each modality of treatment has to be explained to the patient or in the consent form according to the Indian Contract Act of 1872. And the valid consent not only protects the doctor from civil liability but also from criminal liability under section 87 of Bharatiya Nyaya Sanhita Act. I think it's been converted from IPC to Bharatiya Nyaya Sanhita now. The landmark case here, the State Commission held that there was negligence as the case sheet did not contain a proper history of prior treatment, and even the consent papers were missing. So because of which the doctor was punished, the hospital was punished. And so the important message here is have to have a very important, the consent forms. Discharge cards, because they are carried by the patients, they constitute an important piece of evidence. Correlate the mirror the case notes of the patient should always include the instructions to be followed. And the follow-up visits, whom to report to the doctor in case of emergency. Please also mention the telephone number, any emergency telephone number in those discharge cards for which the patient has to contact. So what happened in another case? The hospital was held vicariously liable for the negligent action of the doctor on the basis of discharge certificate under the letterhead of the hospital signed by the doctor. So the discharge certificate was not proper. Machine maintenance reports, oxygen cylinders, ECG monitors, pulse oximeters, all these equipments, their calibration reports, everything has to be maintained properly. And the physician general checkup fitness certificate is very, very important. All medicines, consumables should be of a standard quality. So this is another interesting case happened in Bombay. The post-cataract surgery, the patients developed endophthalmitis. The hospital was negligent as no proper sterilization in the OT was done. And the shortcut methods in sterilizing and fumigating operation theaters were used. So because here what happened was the doctor was a visiting doctor and he chose a particular hospital to operate there, and then there was no autoclave records available in the registered according to the Supreme Court ruling. The said doctor should not have selected that hospital for conducting the surgeries on the complainant when he knew that there was no proper OT sterilization record. So important things, please always have to maintain all the equipments, the sterilization has to be done. The records has to be kept properly. Greatest malpractice risk associated with endophthalmitis shows the analysis of claims. High index of liability arises from the delay in the diagnosis or the treatment, including a delay in referring the patient to a vitreoretinal specialist in case of endophthalmitis. So treat, refer promptly. So another landmark case, the patient underwent cataract surgery in the hospital and visited the hospital next day for the review, and he had some irritation, redness, swelling and everything. He again visited the hospital, advised him to have a cotton roll to wipe the eye, and then the patient was sent back. The complainant contacted the hospital via the phone and he was suffering from continuous irritation, but the hospital did not give an appointment that day. So again he barged into the hospital the next day, but again, the hospital did not heed to it, and a junior doctor examined that patient first, without realizing the seriousness of the complaints of the complainant. The patient was finally examined by the head of the hospital or the person who did the surgery, and then he was referred to the higher center where he underwent treatment, but he did not have good visual acuity. So here, what was the problem? There was negligence. There was no negligence and deficiency in the service on the part of the surgery was done properly, but there was delay in the follow-up, and the diagnosis amounted to the deficiency in the service. So there was delay in looking at the patient and again referring it to the proper vitreoretinal specialist, so because of which the doctor was held liable. So how to beat this? If the surgery was complicated, took longer time, we all know that we should have a high index of suspicions for endophthalmitis. My mentor, Dr. Guru Prasad sir, has given this mnemonic to me, that is to all his fellows, SAVE. What is SAVE? Self-assessment of vision every day. So just keep asking the patient to close that eye, the non-operated eye, and keep seeing daily. If he sees any kind of blurring, then report to the hospital immediately. Educate your staff members. That is very, very important. Instruct them to schedule emergent appointments. Tell them what are the signs and symptoms of endophthalmitis. Even the telephonic operator also should be knowing all these points. Landmark case, the staff members might not be the doctors, but the hospital is vicariously liable for them. So any negligence by these staff, you know that the doctor did not receive that phone call, but the staff received that phone call. So the staff, it's the vicarious liability of the hospital, because the staff were not trained to answer such phone calls. So it's not only just the staff, not only the nurses or the doctors, but also the anesthetist and the surgeon. It does not matter whether they are permanent, temporary, visiting, shadow surgeon, part-time surgeon, or any surgeon, still the hospital is liable. So record all the findings, get the B scan, record daily, and keep a copy with you. Anti-segment and fundus photograph, if possible, should be taken. It's very, very important. So the most important thing is document, 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 document. In doubt, consult with or refer the patients to a vitreoretinal specialist with proper documents. No telephonic treatment at all. A blind telephonic treatment, a recipe for the disaster. So just telephone should be mainly for the appointments and informing only. So what are the measures to be taken to reduce the liability? During the informed consent discussion, warn the patient's attenders about the risk of infection, emphasize the risk, especially if the patient is having diabetes or immunosuppressive drugs. Complications including infection can happen in the best of the hands and the best of the setups, even in the developed countries. So the doctors will not be held responsible under negligence if the treatment is as per the standard textbooks or accepted professional practice, and still the patient suffers loss or injury. Merely because a complication has occurred, then it need not be a negligence. According to the Lakshman Balakrishna versus Triambak on 2nd May 1968, the Supreme Court ruled that the medical man is not an insurer. He does not warrant the successfulness of the treatment or cure of the patient. So negligence, the treatment of standard of care, was not as per the standard textbooks, accepted professional practice, and the patient suffered loss of injury, then only it amounts to negligence. The Supreme Court has also said another important ruling, that negligence shall be from the viewpoint that a doctor who has been accredited with a special skill or competence but does not possess the highest expert skill, it would in such case be sufficient that he or she exercises skill of even an ordinary competent man under a similar scenario. Those persons will not be held responsible. Ophthalmic camps, last 2 points. Camp should not be used as an unsupervised training ground for the postgraduates. They should be a pathologist if prepared, to have a dentist checkup for the teeth, for sepsis, a physician for the general medical checkup. All medicine consumables to be used of standard quality, duly verified by the doctor in charge. So in 1986, the Lions Club Pottery Town in Khurja, UP conducted an eye camp after obtaining necessary permission. So the propaganda what was done was, get operated, go home, no restriction of the food, no bed rest, no stitches to be removed. In response to that, 108 patients operated, the 84 developed endophthalmitis. So after that, the Supreme Court led the guidelines for how to conduct the camps. In a recent case in Dr. NJ in 2018, the cataract surgery was performed on 66 patients at a hospital. On that night, most of the patients complained excruciating pain. The Chief Medical Magistrate Court, which heard the case, convicted the director, the chief medical officer and the chief administrative officer under section 338 for culpable negligence and endangering the personal liberty of the patients and voluntarily hurting them. Because 61 of them lost their vision and 5 of them had partially success. So the court ordered the compensation of nearly around 2.2 to 5.8. So the compensation was fixed based on the Workmen's Compensation Act. So why I am telling this is we have to be very careful, especially in the camp surgery whenever we are doing, because nothing's come for free. Somebody has paid for that patient, so we are still liable for that. It doesn't mean that you have conducted the camp and then something happens, then we will not be held responsible for that. No, the consumer court still holds us responsible is because it thinks that for the charity, somebody else has paid for that charity. So it still becomes under the paid section. So counsel properly, treat, refer promptly, and the only thing I would like to say is document, document, and document, because an ounce of prevention is always better than a pound of cure. Thank you very much for this.
Thank you, Dr.
patient
Shrinivas. Very elaborate discussion about medical